Good evening, everyone. In this lecture, we will discuss briefly ACL injuries. ACL, anterior cruciate ligament, is one of the interarticular ligaments in the knee joint. It has a femoral attachment and tibial attachment. Its femoral attachment is located on the inner aspect of the lateral femoral condyle, and its tibial attachment is in the intercondylar eminence on tibial plateau. Between anterior horn of medial meniscus and the anterior horn of lateral meniscus. Its direction from femoral attachment to tibial attachment is downward, forward, and medially, as if you are putting your hands in pockets, or if you are overlapping the middle finger over the index. Its length is about 25 to 40 millimeters. The average is about 33 millimeters. Thickness from 7 to 12 millimeters. The average thickness is 10 millimeters. It has two main intra-articular bundles, the anteromedial bundle and the posterolateral bundle. Anteromedial and the posterolateral are named according to their tibial attachment. But on the femoral side, the anteromedial bundle is more superior to the posterolateral bundle, as it is directed towards the roof of the notch. The posterolateral bundle, which is located more inferiorly compared to the anteromedial bundle, is much more important, has an extra function related to the control on rotation compared to the anteromedial bundle. The anteromedial bundle is more tight during flexion, and the posterolateral bundle is more tight during extension. There is a debate about the third bundle, extra-articular bundle, which is called the anterolateral ligament of the knee. If it is a true ligament or a condensation from the capsule of knee joint, if it is related to the intra-articular bundles or not. The first one who described the anterolateral ligament of the knee was Segond, a French surgeon, and mentioned its importance and its relationship to the intra-articular ACL. ACL has its blood supply through the middle genicular artery, which is a branch from popliteal artery. Functions of ACL, the main function is to control anterior translation of tibia. It has other functions, as it controls coronal plane instability, whereas valgus instability, mainly valgus stresses. It has also a function in the control of rotation. It is important for the control of rotation of tibia and femur. ACL is concerned more with the control of internal rotation of the tibia, but BCL is concerned with the control of external rotation of tibia. ACL and BCL together are important to control gliding and rolling motion during flexion and extension of the knee. How ACL is injured or torn? The most important mechanism of injury is non-contact injury, pivoting or cutting injuries, like a twisting of the body over a loaded limb in semiflexion and valgus. This is the most important mechanism of injury. Other mechanisms of injury, like hyperextension injury, direct trauma to the posterior aspect of the leg. It may be also the part of high energy trauma and the knee dislocation, the part of multi-ligamentous knee injury. Comparing the risk of ACL injury among male and female athletes, it is much more common in female athletes, 2 to 8 times more common in female athletes. Why? The most important cause is due to valgus alignment of the limb and wider Q angle in females, which imposes higher valgus stresses on ACL and make it more prone to injury. The second cause is the landing mechanism in females in valgus during jumping and running. The third cause is the higher valgus orientation of the heel, which makes the heel or subtalar joint has less capacity to tolerate valgus stresses on the limb. Also, quadriceps dominance in females over hamstring has an important role on imposing anterior translation forces on the tibia. Smaller or narrower notch and smaller ligament has a role. Hormonal factors related to estrogen, progesterone, and relaxin hormone is also an important cause to increase the risk of ACL injury among female athletes. Clinical assessment of ACL injury. First, there is a heard or felt bump in the knee during time of injury. There is pain at time of acute injury, swelling in the first 24 to 48 hours after injury due to hemarthrosis in the joint. As we mentioned previously, it has a blood supply from the middle genicular artery. The sense of instability or giving away is an important sign in long-term injuries. To assess ACL injuries, before doing the anterior drawer test, which is mentioned in the lecture of knee examination, we have to do posterior to check for posterior sagging of tibia. Anterior drawer test, Lachman test, and the pivot shaft test are special tests to assess the integrity of ACL. Radiographic assessment of ACL injuries include doing X-rays to exclude associated fractures and acute injuries, avulsion of the tibial attachment or tibial spine, which may be present in skeletally immature or younger patients. Second fracture, which is avulsion injury of the anterolateral part of proximal tibia, which is a site of tibial attachment of anterolateral ligament, is a pathognomonic sign for presence of injury of ACL. We can do CT for the same reasons. MRI is diagnostic. To check for ACL integrity in MRI, we have to look at the sagittal films at the level of the notch. The intact ACL of low signal, black in color, stretched, not kinked or wavy, continuous, not disrupted, and finally it is steeper than the roof of the notch by about 20 to 30 degrees. If one of these criteria is not present, we suspect ACL injury. But the first criterion regarding the signal of ACL is not very important, as we may see intermediate signal within the ACL, as it has fluid, synovium, and fat within it. So we may see ACL with intermediate signal. But here there is disruption in the ACL, so it is torn. Here it is not steeper than the roof, but less steep than the roof, so it is torn. Here there is disruption. Here it is kinky or wavy, kinked or wavy, so it is torn. We can look at the coronal films to check for ACL injury by seeing, as normal, you can see ACL fibers extending vertically from the lateral femoral condyle and the BCL fibers extending in a horizontal pattern from the medial femoral condyle. The empty notch sign is diagnostic for ACL injury, as you cannot see the vertical fibers extending from the lateral femoral condyle. Treatment of ACL injury. Operative treatment is a standard method of treatment for all active fit patients with no osteoarthritis. Conservative treatment is preserved only for patients who are not fit for surgery, not active, asymptomatic, or those having arthritis. Conservative treatment is by doing RICE as early care, rest, ice packs, compression, elevation, wearing a knee brace, knee mobilizer, rehabilitation, activity modification, preventing pivoting or cutting injuries. But generally it has a poor, it has poor results, poor patient satisfaction, poor patient compliance, especially if the patient is young and active. So the standard method of treatment is operative treatment. It has two forms, repair and reconstruction. If we mean by repair, reattachment of the avulsion of tibial attachment, it is some sort of repair and it is very successful. But repair, meaning to do suture within the torn ligament, is not successful and has high failure rate. Recently, there are some studies discussing how to do repair with good results. Reconstruction, ACL reconstruction, is the standard method of surgical treatment by using a tendon graft, passing it into a tunnel at the femoral side and tibial side, and fixing it on both sides to do the function of ACL. When we are discussing ACL reconstruction, we have to discuss the timing of reconstruction. It is done when the patient has full painless range of motion, unless he has a cause of locked knee, like a bucket handle meniscal tear. But in absence of a cause of locking, the patient must have full painless range of motion, adequate quadriceps strength, and substance and resolution of knee effusion and hemarthrosis. The second issue is the choice of the type of graft. We have many types of grafts like hamstring graft, patellar tendon, less commonly used quadriceps graft, allograft, and synthetic graft. Patellar tendon graft has advantage of rapid healing because it is taken with bone plug, so there is bone-to-bone healing. It is very strong. The strength of patellar tendon graft is about 3,000 Newton. But on the other hand, it has disadvantages of anterior knee pain, preventing the patient from kneeling. It may be associated with iatrogenic patellar fracture or patellar tendon rupture. Hamstring tendon graft has advantage of being harvested from a smaller incision, about 3 centimeters, not associated with anterior knee pain, but it is weaker than the patellar tendon graft, and it needs longer time for incorporation and healing because it is a soft tissue graft. Site of attachment, site of the tunnel, position of the tunnel on the tibial side, as we mentioned before, on the intercondylar eminence, in this, between the anterior horn of medial meniscus and the anterior horn of lateral meniscus, anterior horn of medial meniscus and the anterior horn of lateral meniscus, or about 7 to 10 millimeters anterior to the PCL attachment. On the femoral side, the tunnel of ACL is drilled behind the resident ridge, which is considered the distal continuity of the posterior femoral cortical line. It is done at the level of bifurcate line to avoid doing a higher tunnel, so the graft or the ACL lacking control on the rotation, like in the anteromedial bundle. In the right knee, we are doing the graft, the femoral tunnel at the level of 10.5 clock, and on the left knee we are doing it at the level of 1.5 clock. Types of fixation, we have two types: aperture fixation and suspensory fixation. Aperture fixation is done by using interference screws. Aperture like opening or a slot. So the fixation method is reaching the opening or the slot of the tunnel at the level of the joint. It is done by using interference screw interfering in the gap between the graft and the wall of the tunnel. But suspensory fixation, we are suspending the graft in the tunnel by a fixation method away from the joint, like transfixing pin, like in the bottom and oral loop. Thank you.